Everyone can see the first slide?
Yeah, we can see.
Okay. Hello, everyone. I'm Dr. Nisut Kumar from Rachi. And in the next 20 to 25 minutes, I'll be talking about non-resolving lung opacity. So I'll be showcasing few interesting cases where bronchoscopy guided EBB, that is endobronchial biopsy, or transbronchial lung biopsy, or maybe TBNA, that is transbronchial needle aspiration, helped in clenching the diagnosis. So what exactly is non-resolving lung opacity? We all know that non-resolving lung opacity are a very common problem, which is faced by physicians as well as pulmonologists in our day-to-day practice. It is responsible for up to 15% of pulmonary consultation, which requires hospitalization, and up to in 8% of cases, it requires some sort of interventions like CT-guided FNAC if the lesion is peripheral, or maybe bronchoscopy-guided intervention. So, how to define non-resolving lung opacity? Now, the term non-resolving lung opacity or slowly resolving pneumonia or non-resolving pneumonia has been used to refer to persistence of radiological abnormalities beyond expected time of course. Now, the expected time course for resolution is controversial. There was an article published in Lung India in 2013, and as per that article, the non-resolving pneumonia is defined by the presence of persistence of clinical symptom and signs like cough, sputum, production with or without fever, failure of resolution of radiological features by 50% in 2 weeks or completely in a month on serial chest X-ray in spite of antibiotic therapy for a minimum of 10 days, and sputum for AFP smear negative for 2 consecutive samples. So you all will agree that aggressive investigation as to assess disease nature is warranted in such cases. So what are the causes of non-resolving lung opacity or pneumonia? You can divide the cause into infectious cause and non-infectious cause. And the infectious cause in our country, in our setup, tuberculosis is the number one cause. Then you can have bacterial pneumonia, especially because of resistant bacterial species. Then you can have fungal pneumonia, especially in immunocompromised host, people who are having HIV or on some sort of immunosuppressive therapy. Then you can also have atypical pneumonia, nocardia, NTM, etc. Malignancy is the number one non-infectious cause for non-resolving pneumonia. Then you can have sarcoidosis, which is very difficult to differentiate from tuberculosis in our country, which is very common. Then you can have some rarer causes like pulmonalveolar proteinosis, vasculitis, organizing pneumonia or cryptogenic organizing pneumonia, BOOP, etc. Not that rare. They are missed most of the time, but then you can have them in the list. Then you can have drug-induced pneumonia and radiation pneumonitis, especially in those patients who are undergoing radiation therapy. So, how to approach a case of non-resolving lung opacity or pneumonia? Clinical evaluation, proper history taking is must. Many a time, many a problem will be solved if you take a proper clinical history, whether there is history of smoking or not, and many other things. Then you need to assess comorbidity, whether the patient is suffering from diseases like HIV, or maybe he's on some immunosuppressive therapy, his organ donor, or maybe post-transplant patient. Then complete hemogram, especially if there is raised eosinophil many a times. This also gives a hint regarding the pathology. Then, of course, since in our country TB is very common, sending sputum for Jeden stain and MTB CBNAT is must. Then you would like to send gram stain as well as bacterial culture and sensitivity to isolate bacterial species. Then, of course, AFP culture, pap stain or sputum cytology if you're suspecting bronchoalveolar carcinoma or lung malignancy. And after that, you would like to treat the patient if you're suspecting infectious etiology by adequate antibiotic therapy. If no diagnosis is reached or no resolution is there, despite all these things, then you may need to follow with fiber optic bronchoscopy. You may like to do bronchoalveolar lavage or biopsy. And again, if no diagnosis is reached, you may like to do a CT-guided FNAC or biopsy, especially if the lesion is peripherally situated, or may like to send blood for C-ANCA or serum ACE or other markers, biological markers. So this brings us to case number one. A 73-year-old male presented with complaints of cough, and mild breathlessness exertion since last 6 months. There was no history of fever, weight loss, or hemoptysis. This was his chest X-ray. Uh, he was an ex-army officer. He was a non-smoker. You can see bilateral consolidation. It is almost diffuse with slight sparing of left upper zone and mid zone. So we sent blood investigations and everything was within normal limit. His CBC, LFT, KFT was normal, but ESR was slightly raised. His serum IG was also normal. Sputum AFB was negative. So we did a CT thorax in this patient. So for his radiology, this patient was fairly stable and he was walking around. His saturation was around 96% or so, which was unbelievable. So in the CT scan, you can appreciate bilateral area of consolidation and ground glass opacity with associated interlobular septal thickening. So again, we planned a video bronchoscopy guided BAL and transbronchial lung biopsy. So multiple transbronchial lung biopsies were taken under fundoscopy guidance from left lower lobe, and all those samples were submitted for histopathological examination. Also, we sent BAL sample for fungal culture, AFB culture, and MTB CBNAT along with cytology. So BAL MTB gene expert, MTB was not detected. BAL AB stain was also negative. Again, BAL cytology was suggestive of macrophages, which was admixed with lymphocyte in background of mucinous material and few RBCs. It was negative for malignancy. So what was the diagnosis? It turned out to be a case of lipoid pneumonia on histopathological examination, but there was no history of aspiration of any petroleum product or mineral oil, which was very unusual for lipoid pneumonia. So we again probed the patient and we found out that the gentleman was using liquid paraffin for his dry nostril every day since last few years. So this was basically a case of chronic exogenous lipoid pneumonia. Since the patient was fairly stable, we just followed him up. We didn't give him any steroid or any other thing. We just asked him to stop using liquid paraffin. And again, we followed him up with serial X-ray, and later on, around after 6 months, we did a repeat CT scan, and his opacity almost disappeared. So, case 2, a elderly male presented with complaint of progressive breathlessness on exertion, cough, and weight loss since last 5 months. He was a non-smoker. This was his first X-ray. He visited me in around May 2019. This X-ray was taken in around January 2019. So this was his first X-ray. You can see there's some consolidation in right lower zone along with some evidence of pleural effusion. There is blunting of CP angle. So this was his chest CT, which was done in January 2019. You can see right middle lobe and lower lobe consolidation with minimal amount of pleural effusion and some left upper lobe nodular infiltrate. So the treating doctor thought that this is a case of pneumonia or community acquired pneumonia, and he started the patient on broad spectrum IV antibiotic, which was followed by a course of oral antibiotic for next 2 to 3 weeks. His CBC, LFT, KFT, everything was within normal limit, and sputum AB and CBNAT was also negative. So in March, after 2 months, again a repeat chest X-ray was done with showed increase in lesion size. You can see that there is no new onset opacity, which has developed on left mid zone and lower zone. So the patient also didn't show any symptomatic improvement and was thus put on ATT by the treating physician. So he thought that it's a case of sputum negative tuberculosis, pulmonary tuberculosis. So these are his serial chest X-rays. You can see in from January 2019 to April 2019, there is deterioration in radiology. So again, a repeat chest CT was done, and a large wave-shaped patchy area of consolidation involving anterior segment of left upper lobe, lingula, right middle lobe, and right lower lobe was seen. And there was multiple tiny centrilobular nodular opacity and mild ground glossy involving both upper lobe, lower lobe, and right middle lobe. So on examination, patient was slightly hypoxemic. He was having tachypnea. His BP was normal, and CBC was suggestive of leukocytosis. And again, ultrasound whole abdomen was suggestive of mild GB sludge, mild medicorenal disease, and minimal right-sided pleural effusion. So We did fluoroscopy guided TBLB. Again, few words on TBLB. Uh, Fluoroscopic TBLB significantly increases the diagnostic yield of non-endobronchial lung masses and focal infiltrates compared to non-fluoroscopic TBLB. But there is no clinical significance difference in the rate of pneumothorax. So whether you do fluoro TBLB or non-fluoro TBLB, the rate of occurrence of pneumothorax is almost equal. But the only advantage with fluoro TBLB is that if pneumothorax happens on table, you'll be able to diagnose it at that moment only with the help of fluoroscopy. And maybe if required, you can put a ICD. So again, video bronchoscopy was done and transbronchial lung biopsy was searched for adenocarcinoma. So this was basically a case of malignancy which was misinterpreted as tuberculosis initially. So again, a 46-year-old male presented with complaint of dry cough, breathlessness on exertion. He was having low-grade fever, weight loss since last 1 year. The symptoms were progressive. There was no past history of anti-tubercular drug intake. He was a non-smoker and vitals were fairly stable for his age. This was his radiology. As you can see, there is bilateral hyaloprominence, suggestive of hilar lymphadenopathy. I don't know if you'll be able to appreciate the reticulonodular opacities in this chest X-ray. We did a CT thorax for this patient, and I'm sure you can appreciate widespread mediastinal lymphadenopathy, right hilar, subcarinal, as well as right paratracheal lymph nodes were enlarged, and there were irregular nodular thickening in perilymphatic distribution, and also there was patchy area of fibrosis with some amount of traction bronchiectasis in left upper lobe. So again, investigations were sent. CBC, LFT, KFT were normal. MON2 was negative. Serum ACE was elevated. Serum calcium was also slightly on the higher side. So again, video bronchoscopy was done. You can see mucosal edema in secondary carina. So multiple endobronchial biopsies were taken from endobronchial mucosal granularity. I'm sure you can appreciate endobronchial mucosal granularity in the second pic on the right-hand side. It is characteristic of a disease. It is called cobblestone appearance. So TBLB, TBNF from subcarinal lymph node and right paratracheal lymph node, as well as EBB. Sampling was done and everything was submitted for investigation. Also, bowel sample was collected from both the lower lobe and it was submitted for MTB-CBNAT and AFB staining. So, again, a few words about conventional TBNA. Of course, EBUS guided or linear EBUS guided TBNA is the best modality for targeting mediastinal lymph node. There is no doubt about it, but also, EBUS guidance significantly increases the yield of TBNA in all stations except subcarinal region. So, if you are having enlarged subcarinal lymph node, the yield of conventional TBNA and EBUS guided TBNA is almost similar. So, the yield of conventional TBNA is around 58 to 74%, which is not that bad, especially since there is a huge cost difference. And the diagnostic yield of conventional TBNA plus endobronchial biopsy and TBLB. So if you're suspecting sarcoidosis in a patient and if you're doing conventional TBNA along with EBB and also you're combining TBLB, transbronchial lung biopsy, it is similar to EBUS TBNA plus TBLB. So for sarcoidosis, conventional TBNA, EBB and TBLB is enough. So coming back to the case, his BAL AFP fungal culture were negative, BAL cytology was negative for malignant cell, and EBB for HPE was suggestive of non-caseating granuloma. Also, TBNA from mediastinal lymph node was also suggestive of non-caseating granulomatous lymphadenitis. So basically, it was a classical case of sarcoidosis, and he was started on oral corticosteroid, and he did quite well with it. So this brings us to second last case. Again, a middle-aged patient presented to us with cough and shortness of breath since 1 year. He was having episodic hemoptysis since last 6 months. There was no history of fever, weight loss, chest pain, or change of voice. He was a non-smoker. There was history of ATT intake because of his radiology, chest radiology. It was prescribed by some other physician. So he took ATT 4 months back for 2 months, but there was no relief, so he left on his own. His sputum AB was negative. This was his chest X-ray. You can see right upper zone and mid zone homogeneous opacity. So again, CT thorax was ordered, and I'm sure you can appreciate consolidation with breakdown changes, air bronchogram, and calcific speck in right upper lobe with mildly enlarged mediastinal lymph node. So again, CBC was suggestive of slightly raised absolute eosinophil count. Other investigations were fairly normal. Sputum A, B, and CBNAT were negative. Total serum IG and serum IG specific for aspergillus fumigatus were sent because I was suspecting ABPA in this particular patient because I thought that there is some evidence of mucus impaction in right upper lobe, and also his absolute eosinophil count was slightly raised, but it turned out to be negative within normal limit. His ANCA screen, that is C ANCA and P ANCA, were also sent, but those were also within normal limit. So we did a video bronchoscopy in this patient, and as you can see, there is marked mucosal edema in right upper lobe bronchus. The opening is almost narrowed, and there is a suspected growth which can be seen at the opening of right upper lobe anterior segment. So multiple biopsies were taken from abnormal endobronchial mucosa and also from the suspected growth, and everything was submitted for histopathological examination. Bowel fluid was also collected and was submitted for malignant cytology, fungal stain, and AFB stain along with MTB CBNAT. So, bowel AFB, fungal culture, everything turned out to be negative. Bowel MTB CBNAT, MTB was not detected. EBB for HPE was suggestive of necrotizing granulomatous inflammation, and also bowel fluid cytology was negative for malignant cells. So, what it is? In Indian context, necrotizing granulomatous inflammation will almost always be equal to tuberculosis. But since with such a lesion, it is almost impossible to get a bowel MTB CBNAT negative if it's a case of tuberculosis in a immunocompetent patient. So basically, this was a diagnosis of exclusion. So a diagnosis of bronchocentric granulomatosis was made after excluding other possible causes like malignancy and tuberculosis, and patient was started on oral corticosteroid. So this was his X-ray with oral corticosteroid after 3 months. You can see there is marked resolution, remarkable resolution. So this brings us to sixth case, and this is also the last case. A middle-aged male presented with complaint of progressive breathlessness on exertion and cough. He was not having any comorbidities. His saturation was 88%. He was slightly hypoxemic. He was having digital clubbing. His CBC, LFT, KFT, everything was within normal limit. There was no feature suggestive of CTD. There was no history of exposure to any occupational. There was no history of occupational exposure or to any dust exposure. He was a non-smoker, and sputum AFB as well as HIV status was negative. So we did HRCT thorax for this patient, and as you can see, there is bilateral smooth thickening of interlobular and intralobular septal line and ground glass opacity. This is classically called crazy paving appearance. So this is again a hallmark of a disease. So bowel fluid examination was done, and again MTB was not detected. There was no fungal culture. Fungal culture was sterile. There was no growth, and you can see the bowel fluid. It is slightly milky and turbid. So bowel pass was positive. This was basically a case of primary pulmonary alveolar proteinosis. And just to emphasize that even a simple bowel can lead to a diagnosis. In many instances, you don't require TBLB and TBNA in all the cases. So again, this is the last slide. Non-resolving pneumonia is often an area of clinical dilemma which we all face in our day-to-day practice. Bronchoscopy, even conventional bronchoscopy, is an extremely safe and cost-effective diagnostic as well as therapeutic modality. Therapeutic because even with a conventional bronchoscope, many times you can take out foreign body in patients who are admitted in ICU who are having lung collapse because of secretion. You can take out those secretion that can lead to proper aeration of the affected segment or lobe. And also, early bronchoscopy is quite helpful in establishing diagnosis in cases of suspected lung cancer, mediastinal lymphadenopathies, and non-resolving pneumonias. Thank you so much. Thank you so much.
Thank you, Dr. Nishit, for your lovely presentation. Just a couple of things. Firstly, I just wish to introduce myself. To all the attendees out there, my name is Hardik Shah, and I specifically take care of the respiratory marketing for the Olympus market for eastern and western part of India. And the other thing is, any questions and queries that you have in your mind, please drop down the same in your question answer session. There is a section box at the bottom which says Q&A. You can all type your questions there, which will be answered by our faculty subsequently. So please avoid raising hands and writing down in chat box. You can drop your questions in the Q&A box. Okay, we'll start off with the second presentation from Dr. Naveen. You can take over the podium.